Next up on our agenda is our first spotlight presentation of a medical provider toolkit for protecting patient privacy. As you'll hear, this effort grew out of clinicians who had experiences much like what we just heard about and who undertook the research to develop this very practical tool that outlines the rights and responsibilities of healthcare providers in similar scenarios. This toolkit is supposed to be ready to use. It's also posted on our conference website, and I hope that if you haven't taken a look yet, you'll be inspired to check it out. Presenting are two key members from the team that developed this toolkit. Carly Loughran is originally from Chicago, Illinois. She received a bachelor's in neuroscience from the University of Notre Dame and is currently in her third year at Georgetown Law. Jake Sonnenberg is a medical student at the University of California, San Francisco. He also holds a JD from Stanford Law School and previously served as a special assistant and policy advisor to U.S. Senator Michael Bennet. Both Ms. Loughran and Mr. Sonnenberg are members of the Working Group on Policing and Patient Rights, a national collaboration medical providers, lawyers, and graduate students committed to advocating for patients' rights in the emergency department. We're so pleased to have them.
I'm just going to share my screen here. Those slides up, Carly?
Yes, I can see them.
Awesome. Well, hi, everybody. I'm Jake. Carly, do you want to say hi quickly? And
Hello, everyone. Thank you so much for being with us today. As previously mentioned, my name is Carly Loughran.
And I'm Jake, like I said. Thank you all so much for having us here. And hopefully this will be a good follow-up to the really great conversation that we just listened to. In the interest of time, I think we'll just jump right into it. So I'll pass it back to Carly to get us started.
So we are presenting this toolkit today on behalf of the Working Group on Policing and Patients' Rights. Our working group was created by Georgetown's Health Justice Alliance to find solutions to policing issues in the emergency department setting. Our team is made up of doctors, lawyers, students, and social workers from across the country. And the real main mission of this working group was to create a set of policies and best practices that we could all not incorporate into our own work in hospital systems, but could also provide others and could contribute to the national dialogue on these issues.
So I'm going to give a bit of background on where this project came from before we jump into things. As many of you know, and as a lot of the panelists talked in the previous discussion, a salient finding from the literature on policing in healthcare across many different disciplines is that police presence in hospitals can create areas of legal and ethical ambiguity that put patient rights at risk. And this can happen in many ways when police are active in hospitals, especially when their presence is unregulated. So some of these ways include police simply overhearing protected health information shared in a patient care area, as was discussed by the previous panelists. Some of this can be clinicians providing law enforcement with information or access to patients or their property that the police are not actually legally entitled to have. And sometimes this can just be the implied authority of police presence limiting patient autonomy or their ability to make decisions on their own. Sometimes it's police access to patients undermining their constitutional rights to refuse to speak with the police, or the presence of police exacerbating existing racial disparities that already are present in healthcare. And while all these things are recognized more and more as a problem, there's still very little information available about how clinicians, patients, and other stakeholders can limit the negative consequences of police activity in healthcare settings right now. And so that's really what we focused on in this toolkit. Alongside all of the incredible research that's going on out there and the organizing efforts to affect change in policing and healthcare, we wanted to provide information that we could offer to clinicians right now to put into practice.
So as Jake mentioned, our toolkit was designed to make legal issues surrounding policing in the emergency department accessible to medical providers. While none of the information presented in the toolkit constitutes legal advice, it can all be immediately implemented into care. The toolkit was created for medical providers, and it's organized around a series of frequently asked questions, some of which include, do police have a right to be in my ED? How do police enter my ED? How can police presence in the ED harm patients? How can I better advocate for my patients' rights? By answering these frequently asked questions, we hope to communicate why these issues are important, but we also really wanted to empower medical providers in their interactions with law enforcement. A large portion of this toolkit is devoted to scripts designed to help guide medical providers through various real-life scenarios they may encounter when interacting with the police. We believe these scripts are one of the most powerful aspects of the toolkit, and so we're going to spend the remainder of our presentation discussing and walking through these different scenarios that we've developed. Our first set of scenarios involves approaching law enforcement officers. So police officers are often given unrestricted access to emergency departments. They often are allowed to walk around and loiter in areas of the ED where other visitors are not permitted, even if they don't have a clear reason for being there. The script designed to address this reality is based on the legal distinction between public and private spaces. Emergency departments should not be treated as public spaces. Police officers should be treated like any other visitor entering the emergency department and be subject to visitor protocols such as signing in and showing identification. By allowing police unrestricted access to EDs, hospitals are actually eroding patient privacy rights. Like any other visitor, if a law enforcement officer isn't visiting a specific patient with that patient's consent, they should be asked to leave the emergency department and return to the visitor waiting area. If a medical provider encounters a member of law enforcement in an area of the emergency department that is restricted to visitors, they should approach the officer, record their name and badge number, and if the officer doesn't have a valid reason for being there, should ask them to wait outside the ED. Even the simple act of asking an officer for their name and badge number can help create an environment of accountability for law enforcement and foster privacy and healing for patients. The second set of scenarios covers how providers can preserve patients' rights to withhold consent. So police who enter the ED often want to talk to patients, even if those patients might have been given medications that can impair their thinking or in extreme pain or have an altered mental status. Patients always have the right to refuse to speak with law enforcement. Like anyone walking down the street, patients are not required to speak with the police. Even patients who are in custody can always exercise their constitutional right to remain silent. Medical providers can help preserve patients' rights by acting as a buffer between patients and the police. Medical providers should always inform patients of their right to refuse to speak with the police. Hospital beds are not interrogation rooms, and thus, police should not be given access to any patient who refuses to speak with them.
The next scenario here, a common scenario that clinicians often encounter, is police arriving in the emergency department and asking, or not even asking, to search or take a patient's property. And from the standpoint of constitutional law, police would almost always need a warrant to search a patient or their property or to take something that belongs to them without their consent. And police actually often get around this requirement in the ED by getting patient property secondhand from hospitals and healthcare workers. It's actually a kind of convoluted legal situation, but the bottom line is that under a constitutional principle known as the third party doctrine, when the police receive property from a so-called third party intermediary, for instance, in this case, a hospital, rather than directly from the person that they're interested in this case, the patient, the police actually circumvent the need for getting a warrant. So by turning patient property or information over to the police or conducting procedures at the request of police, hospitals can actually be insulating the police from legal liability and giving them access to physical items that they wouldn't otherwise have. So what we recommend in the toolkit is that clinicians say no to these requests as much as possible. You can say things like, we don't consent to this search or seizure, and neither does the patient. Or we're not giving these items to you, or at least we're not giving them to you willingly. The important thing here is to emphasize that there's no consent being given on either your behalf or on behalf of the patient. And then the final step we really urge people to implement is to document what happens in the medical record and to pass along that information about what happened, to the patient's lawyer. The next scenario here is pretty similar to the previous one, so I won't spend too much time on it. It's really that the police are often asking for information about particular patients. What's their status? What are their injuries? Are they going to live? Who did they come here with? What were the toxicology screen results? And these are all questions that were brought up in the previous panel. And the important point to emphasize here, again, is that Police, if police want this information, they can always go get a warrant or subpoena a patient's medical records if there are valid legal reasons why they have a right to get that information. And alternatively, if there is a real emergency and they need the information now and they have a legal right to the information now without a warrant, they will make that clear to you. Or they can speak with your hospital's legal counsel or someone else who's authorized to really answer those questions. The important point we try to emphasize is that there's nothing anywhere that requires you as a clinician to give any information to the police right there on the spot. It is true that there are parts of HIPAA that allow for healthcare workers to disclose certain limited information under very specific circumstances to law enforcement officers without patient consent. And police frequently bring this up in the clinical setting. But with very, very limited exceptions, these are discretionary disclosures. They're not mandatory. And they're much more limited than most people realize. The third thing we want to talk about is really getting at how complicated all of this that we've just been going through is, and how it can feel like a lot of legal analysis that is really probably too much for any one clinician to handle while working an already busy job. And it really leads into our final recommendation that we hope will be a takeaway message for all these interactions with police, which is that it isn't a clinician's job to be a doctor or a respiratory therapist or a nurse or a social worker, and to also be their lawyer at the same time. So if police are asking for things or showing you warrants or paperwork to evaluate, or they're demanding something right away, what we hope you'll remember is that it isn't your responsibility to evaluate the legality of those requests or to take any immediate action. Police requesting protected health information, for instance, speak with the appropriate hospital administrators, just like anyone else asking for that information. So our third big set of recommendations is to refer these warrants to the appropriate authorities. So the final script is just putting some language to that point. It's hopefully a helpful example of how to send the police to someone who might actually be better situated to evaluate their requests. And hopefully this builds a partnership and improves law enforcement's experience as well, because they can be directed to the right person to actually answer their question and get them the information that they might actually be entitled to. And the flip side of this is that if your patient actually might benefit from speaking with an attorney too. So maybe that means getting them on the phone with a public defender, or even recommending to them that they talk to a lawyer before they talk to the police. And to bring this discussion back to where we started, to wrap up, we want to emphasize that policing in hospitals right now, as was discussed again in the previous panel, really does operate in a lawless vacuum where there's a lot of procedural ambiguity and a lot of unclear responsibilities. And that means ultimately that decisions that are very important for patients and have serious consequences end up getting made on the fly on an ad hoc basis. What we don't talk about very often, though, is that hospitals play a huge role in creating this lawlessness. Hospitals are really the ones that decide what happens, because so much of what is currently going on with police in hospitals is neither explicitly required nor is it explicitly prohibited by the law. So hospital decisions really, and policies and practices ultimately define the boundaries of what ends up happening. And right now, hospitals have largely set policies that align with the interests of law enforcement, or at least they haven't staked out positions that align with the interests of patients. And what we hope to do ultimately in this work is to reframe the conversation, get hospitals to say, patients come to us at their most vulnerable. They're sick. They may be victims of a crime. They may be isolated from friends and family. They may be experiencing the most traumatic day of their lives. And because of all this, we as a healthcare system are going to have policies that protect our patients to the greatest extent permissible under the law. And this slide is just a list of some policies that we have identified as being ones that should be targeted for change. We don't have time to get into the nuances of any of these today, but the same basic point is true for all of them. These rules need to be rewritten with a new guiding question in mind. What is ultimately best for our patients? So thank you all so much for having us here and for inviting us. If there are any questions, we'd love to hear from the audience.
Thank you both for that presentation. I will ask one question that's come up a couple times, and you only have like 30 seconds to answer it, which is, what was the collaboration with law enforcement in creating this toolkit, or what have your conversations been since the speed version?
Yeah, so our team, as we mentioned, is kind of came at this issue from a medical provider and patient care perspective. So no law enforcement were actually involved in the making of this toolkit. However, we think collaborating with law enforcement is extremely important when taking some of those next steps that Jake described. Law enforcement officers are doing their job as well, and I think there is an efficient and effective way that they can be incorporated into this conversation without sacrificing patients' privacy rights. And I think often this conversation is kind of framed as an either safety and security or privacy, but I really don't think that needs to be the case. In the perfect moment for law enforcement to join the table and kind of have these conversations is during that implementation and policy piece.
Thank you both so much. And I really do encourage everybody to take a look at the full toolkit. It is awesome.